Hello and welcome back. I'm Eric Sunset, your host of the DocBuddy Journal. We've got a familiar face on today. We're joined again by Marc Ryan. Marc is the Chief Solutions Officer with Lilac Software. Marc, how you doing? Thanks for coming back on.
I'm doing great, Eric. Nice to see you again, and I really love doing these.
Yeah, I do too. This is such interesting subject matter. We talked last year kind of in the run up to the election and talked again after the election. And there's a lot of sort of opacity on what's going to happen. If you had a crystal ball and could see into the future, you'd have a pretty good idea. But things are starting to crystallize a little bit, as it were. So I know we want to talk a little bit about how the landscape is solidifying.
Absolutely.
But before we get into the heart of the episode, I know you had a couple thoughts, sort of an exciting development in your personal life related to one of the hottest topics in healthcare right now. I don't want to steal any of your thunder, but please enlighten our audience.
No, that's great. You mentioned to me when I got on that I looked a little bit different over the months that I've been on here. And I told you that I am now on a GLP-1. I'm on Manjaro. I've just reached the age of 60. And when you have type 2 diabetes, it tends to start inching up into that danger zone. So I'm really conservative on medications, but my doctor and I talked about it, and I made the leap to going on a GLP-1. And I was a skeptic. I don't like being on, brand new drugs. I like legacy drugs because I know they're sort of proven and things like that. So again, I'm a little cautious, but I decided to make the leap because my sister went on it as well, and she had a lot of great outcomes. I've lost 50 pounds in about 9 months. All of my numbers that historically were high, my hemoglobin A1C, my cholesterol, my statins, my triglyceride, all of those things have literally come down into the normal range. And I feel great, right? I lost a little muscle mass, which people have to watch. But otherwise, I'm vigorous and I really feel good. And I'm down 70 pounds total, 50 pounds on the drug. But it really is amazing what these drugs can do. And it got me thinking that, I have a great retiree health plan from a government. And so I literally pay nothing for that GLP-1. So the high price of a GLP-1, which runs $1,000 to $1,300 list price, is not an issue for me because I'm privileged to have great health care. And, I have done well in my life anyway, right? So even if I didn't have great health care, I probably could afford it. But it led me to really think about the fact that most people, either through means to pay on their own or through health insurance, where many of their health insurance doesn't cover it just for weight loss, or they may have a very high out-of-pocket cost. They may have a deductible before it's covered. It's a huge barrier to getting on a life-changing drug. And we often talk about, people on insulin having to go to Canada because it was so expensive and things like that. But it really led me to think that drug prices in this country really are sort of hurting people's health and hurting people's access. And GLP-1s is a great example. I am sort of saying Medicare probably can't afford to cover it right now because of the explosive costs, right? And it ends up hurting other parts of the health sector. But if we could get the price down, I think a lot of people could really benefit from it as long as they stay on it, they exercise, they eat right too. All those things are really important. And when you're on the drug, you have a change in psychology to say, I'm going to eat better, I'm going to exercise more, things like that. So I was very pleased. I don't agree with Donald Trump on everything. I'm a Republican, but much more of a moderate guy. But I was very pleased to hear him on Super Bowl Sunday say, hey, these GLP-1 drugs are about 10 cents on the dollar in the United Kingdom. And frankly, he had studied the issue. He's absolutely right. And I really believe he's going to do something on this front. We'll sort of get into the policy now. It appears that his administration is going to keep the Medicare drug negotiation law. Dr. Oz, who is now the CMS administrator, wants to do that as well. So I think, contrary to popular opinion, Big Pharma loses that debate. I think the populism in Trump keeps the law. And I think over time, you're going to start to see changes in drug pricing, right? I think I give Joe Biden a lot of credit for starting it, but I think hopefully Donald Trump will continue that because I think it really is a question of equity with other nations. uh, we're basically paying for other nations' GDP and even subsidizing their healthcare system in general. And this would really be a great thing for Americans if they can have better access to drugs at much lower costs.
That's a huge accomplishment and a huge achievement. And Mark, you were like the poster child for the right application of the GLP ones. Obviously, we've had prior guests, doctors, surgeons of different types. I'm not qualified to give medical advice. I'm not a doctor. I know you're not giving medical advice, Mark. If you are curious about GLP ones, talk to your physician.
Yep.
Do not the advice of our surgeons and doctor guests on the show. You have no business going online and ordering them to your door without the oversight of your physician. So
Absolutely.
just word to the wise there.
Real true. Whether it's just weight loss or it's in combination with a disease state, right? And by the way, a caution: there are a lot of scams. There's a lot of fakes out there. This is one area where people are falling for drugs that aren't really drugs or drugs that could actually harm you. So just be very cautious. There are still some compounding ones out there that are probably okay if you know who the compounder is and you work with your physician. That may go away due to patent infringement lawsuits and things like that, and the shortage not being there. But Eric, you're absolutely right. You got to be very cautious. It's got to be done deliberately over time and things like that.
Yeah, if you're not qualified to know yourself, then your physician is your next phone call.
Yep.
So we'll move past the red tape there. You said something interesting, and turning our attention to the heart of the show, that we've been subsidizing other nations' GDPs. Obviously, this is maybe tangent to what you really want to talk about today, but with the Department of Government Efficiency and the uncovering of all the USAID information, and I only know what they tell me. I'm not in Washington. I can only read what's being reported on, and certainly I'm big grain of salt type of guy. But what you just said really rings true, that there seems to be tremendous amounts of money flowing to all corners of the earth, and maybe that's going to stop. Maybe that's not. There's judicial injunctions in place to prevent some of these things from being carried out. The stopping of these things from being carried out. What, from your perspective, Mark, what does that look like in terms of healthcare? What could potentially be changing? Is there anything that's caught your eye in the Doge sense?
Sure. Let me touch upon the sort of subsidizing the GDP issue. As I did some research here, and it's absolutely amazing. So the Mounjaro drug and its counterpart for weight loss, Zepbound, is manufactured by Novo Nordisk, which is a Danish company. And it's interesting. We talked earlier about Greenland and all those things going on with Trump. And Greenland is a Danish autonomous region, so to speak. But literally, there are statistics today that says that the growth in trade exports from Denmark, as well as the GDP growth, has very much been because of Novo Nordisk and GLP 1s. And essentially what's happening, and I'm sort of more of a anti-tariff, free market guy, and don't totally agree with Trump on those things. But I do agree on this thing. Essentially, we are being taken for a ride by all brand pharmaceutical companies, but especially foreign ones that have cut deals to have very low prices in Europe. And I'll give Europe credit for driving lower prices. But then those foreign companies and even domestic ones, because even our US based domestic ones are multinationals, they've all come together to say, I am going to get all of my profits and all of my revenue in essence from America. And I am going to cut deals in foreign countries for very low drug prices. It becomes gravy. But the lion's share, anywhere from 2/3 to 3/4 of brand drug makers' profits across the world, regardless of where they're based, is from America. And most of that American profit is from Medicare, just given the drug utilization. And so it really leads to the question of why are we subsidizing foreign GDPs? Why are we subsidizing, in essence, the healthcare systems of other countries? Because they benefit from low drug prices, lower cost, where we have the highest cost and very high drug prices. So it's I believe Trump's right on attacking this one. I may not totally agree with all the tariff policy and things like that. And I actually think some of the tariffs will increase healthcare costs for different kinds of durable medical equipment and other supplies and even drugs. But it's a very interesting thing if you really dig down into Denmark's GDP, where it came from. It's all about having Americans pay excessive prices on drugs, especially weight loss ones.
Well, and that brings to mind a talking point over the last 30 years or so. I think there's been a little more enlightenment in the last 5 or so years, and people that should know already know what you just discussed around a domestically high price and an internationally, artificially low price. But the talking point from big pharma, if you will, was that it costs money to research and develop new drugs. You pay so much because you want the next new drug, right? What if the next new drug cures X, Y, or Z? Well, of course, these don't just fall off the tree. We have to pay to research and analyze them. That doesn't seem to have been the case, though. Simply put, America was just footing the bill for essentially these pharma companies' R&D,
Yeah,
as opposed to our friends at the EU.
absolutely. And I don't dismiss the idea that innovation could be impacted, but I think there are ways around that. And I'll get back to the Doge question here in a second because I want to tie it in. But if you look at innovation so far since the Medicare drug law passed, there's no evidence yet that it is impacting research and development and innovation in the sector. Now, we're a little early in it, but the chicken little, the sky is falling argument from brand big pharma has not come true, right? Now, again, innovation could be impacted, but I would say a couple more things. One, if we can lower our price, maybe foreign prices have to increase somewhat. And that's where we get some of the innovation monies back, right? Number two, if you look at a lot of innovation in the drug sector, it has not been what I believe is true innovation for health. It's been innovation for big pharma's bottom line. They are picking drugs that they think will drive the best margin. And I don't doubt that they help certain people, but they are not developing, perhaps with the exception of GLP-1s and a few others, things that are really going to profoundly improve health across the world or even in America. And they also have invested a lot of money in copycats, where they are seeking to extend patents on drugs by cosmetically changing them and things like that. So, again, I think the innovation monies are not going away. A lot of innovation monies have not been spent wisely. Maybe the foreign governments have to step up and pay for some of the innovation. And last, coming back to Doge, I believe in government investment. And I think if you look at drug innovation and other innovation in the nation over the years, really since World War II, the science grants and the investments that NIH and other agencies of the US government has been very beneficial. And my fear right now with Doge, I'm a former state budget director. I do believe there's waste in government. So I support the idea of going in and, with a larger scalpel than usual, but not a hatchet, going in and maybe doing things because our debt is incredible. But my criticism of what's going on right now, whether it's layoffs or holding up funding, is it is too quick, it's scattershot, and it really is impacting important things. There's a great statistic out there that said some of our science and healthcare investments have increased our productivity dramatically since World War II. And I think it's about a quarter, if I remember the stat. A quarter of our increased productivity came from some of these government grants. And as we know, we are highly more productive than virtually any other developed world nation. Germany is pretty productive, but if you look at the rest of them, productivity is low. And we thrive and survive on our productivity in the US. We have a whole bunch of barriers and costs that hurt us, but we thrive on the ability to be more productive. And unfortunately, I think getting rid of some of these research and other grants impacts innovation as well as productivity in our country. So I think we have to be much more balanced in terms of what Doge is doing. Although it's a good idea, its time has come.
Sure. Yeah, it'll be interesting to see. I mean, you're right. The pendulum has swung, not just a hatchet, but how about a chainsaw?
Exactly. And we've seen chainsaws, right? So,
Right. We'll hopefully end up back in sort of a happy medium, as you pointed out.
yeah.
I know there's a couple thoughts that you had on some of the interesting dynamics that are in place in Congress. Not to fly through any of
Yep.
our
Sure.
discussion points, but Trump's got his cabinet in place
Yep.
and got everybody but his CDC director Dave Weldon installed, for lack of a better term. Take us from there, Mark.
Yeah. So, interestingly, contrary to popular wisdom, Trump got pretty much all of his healthcare appointees, right? So, Weldon at the CDC was the one exception, actually. He sort of was an anti vaccine skeptic. And even though RFK Jr., who was confirmed, was a skeptic too, they sort of went after Weldon because they really couldn't go after Kennedy, right? So he got Dr. Oz, he got Kennedy, he got Marty McCary, who I think very highly of, who is going to lead the FDA. He got his NIH director, and there's still a couple more out there, but he actually got his healthcare guys. I know some of them were controversial. I'm sort of a guy that says a president deserves the guys he wants as long as they're fairly reasonable. And I think the Senate actually did a good job of looking at that and getting some commitments from Kennedy, for example, that he would be balanced and things like that. So that's one good development by the president. He sort of got people that people thought they wouldn't. They passed a funding bill for FFY 25, which ends in September. So that's a success story. We will reach the debt limit in August. So we believe that a budget reconciliation bill to extend the Trump tax cuts will be passed anywhere between May and August. It's still going to be a very tough fight. The vote counts in the House and the Senate are very close, and some moderates could jump off if cuts are too extensive. But the GOP is fighting for those cuts because extending the tax cuts cost money over the budget horizon. So they don't want to inflate the debt and deficit too much. So they're looking for several $trillion over the 10-year horizon in cuts. Many of them are slated for healthcare. At the same time, Trump and even some House GOP and Senate GOP leaders have said, we're not going to cut Medicaid or Medicare in terms of coverage. We're not going to take it away from people. But if you look at the bogey, almost $1 trillion, 880 billion over 10 years in the House, it's almost a question of how do they do it without impacting coverage, right? They're talking about waste, fraud, and abuse and things like that, but there's not enough money really out there. So my theory is they may not go after redefining the programs like Medicaid in a fundamental way, but they're going to find ways to reduce fraud, waste, and abuse, curb provider taxes that drive spending and things like that. There will be coverage impacts because when you start taking hundreds of millions of dollars over a horizon out of any program, there will be coverage impacts. But I say they're trying to thread the needle. How do they say, I didn't fundamentally impact your coverage, but I did find savings to pay for the tax cuts? So that's sort of where we are now. We'll know whether the bill passes. I think it will, but how big those cuts will be and what the impacts on coverage are is sort of the real unknown. And, I say there's a lot of dynamics in Congress. If I could jump to that one here. Again, you have the tight vote counts in each chamber. You have some moderate voices in each chamber. Some of my favorite senators are Lisa Murkowski and Susan Collins on the Republican side. They're sort of pro healthcare coverage, but reasonable people as well. And they want to sort of watch spending. So I think that's the good mentality. They're going to be very important in the vote in the Senate. In the House, they're getting much fewer in terms of moderates in the House, but there are still several dozen, and they will play a role. There are swing districts in the House and in the Senate, so to speak, that will come into play. The GOP does not want to lose their majorities in either, but a swing of a couple of seats in each chamber could do that. So even some of the Republican leaders and people in the swing districts are concerned about deep cuts. You have something called the GOP Doctors Caucus in each chamber. There's about a dozen doctors in each chamber that are have sway, and they tend to be pretty pro providers. So they're going to be watching for cuts that impact providers. States have tremendous influence. They don't want to see the reimbursement cut. And lastly, I'd say Trump is actually now looking at his legacy. He can't run again, or so we think. We don't know what he's going to do, right? But he can't run again. And he is looking a little bit at his legacy. He wants to be known as a reorganizer and extending his tax cuts, but he's also worried about looking too cut oriented in impacting the voters that got him back into office. So all of those sort of six or so things come together to create a dynamic in budget reconciliation that, number one, is fluid and it changes by the day. And number two, raises a lot of issues about exactly what's going to happen. So I hope that helps as an update.
Oh, absolutely. And one of the questions I have for you, Mark, looking at the patient side of Medicare, looking at the provider side of Medicare, since the 25 fee schedule was
Yep.
released in October, I guess, late last year, Q4 last year, every single stakeholder on the provider side, whether they're an administrator, a business office manager, a provider, a surgeon, a nurse, whatever, nobody's happy about that. Nobody's happy about the 25 fee schedule. They keep paying us less and they keep asking us to do more. It's ridiculous.
Yep.
You look at the coverage and the out of pocket that patients have to endure to have any amount of what you could consider real care. When do we have to rip it apart and put it back together? Because it's not really working for anybody at this stage.
I think you're absolutely right, Eric. And um, I believe that we are at that point now where the system becomes unsustainable. I'll give you a quick stat here. Employer coverage in 23 and 24 and into 25 will grow at an annual rate. The cost of healthcare for employers will grow between 6 and 8%, 23, 24, and 25. We have some of the stats and we have projections. And in 26, it will grow another 6 to 8%. So if we just say it's 7 times 4, close to 30% increase in 4 years in employer costs. Now we know that about half of the nation is covered with employer costs. And employers have tried to hold their employees harmless. They've done a pretty good job. They've taken up more of the cost, but they've passed on a little. But more and more employers can't afford that. And we are starting to see seepage. We're starting to see employee share of premiums go up. To your point, we're seeing deductibles and benefit erosion. And that is causing what I call, you may not be uninsured like 28 to 30 other million people, but there are probably between the uninsured and the underinsured, somewhere around 85 million in the country, about 25% of the country, that are either uninsured or, more importantly, underinsured, because the cost that they have to pay out of pocket to access their insurance and get into the healthcare sector is too high. And what happens is people delay costs, they delay tests. And if you look at the statistics, that is causing morbidity and mortality in our country. And so we do have to fundamentally do something different. I am sympathetic to provider rates in Medicare. with the exception of the hospitals, and I'll go into that in a minute.
Well, right, right. They're in their own zone
Yeah.
when we're
But
discussing
if you
this.
look at physicians, other providers, even some facility operators, the rate increases, if they are at all, I think are very low, especially with the utilization happening right now. The doctors are the most hurt, right? Because once again, we had two bills passed to continue funding into fiscal year 25 to the end September 30, and they did not get fixed, right? They have a 2.8% decrease. Their real reimbursement has dropped dramatically over the last several decades. And what has it done? I mentioned it last time. It has caused an erosion of primary care as well as independent practices in this country. So we have to fix reimbursement. I think there are ways to do that. We have to rein in hospital costs, they're out of control. And I believe we need to equalize rates across all lines of business. I'm a believer, and this sounds a little like price control, but you know what? The healthcare sector is not a free market anyway. And I think you
No.
would have greater transparency if you set up a regional or national system, depending on the type of provider, and equalized rates across everything. We might have to spend slightly more money in some places in Medicare and Medicaid, but it's worth it if we can bring down the cost of commercial insurance, give providers fair rates across everything. It will bring greater transparency. It will encourage efficiency in the health plan sector, in the provider sector. And you then suddenly could benchmark increases to quality better. And you could benchmark it better to utilization increases, inflation, and things like that. But right now, as you mentioned, we just have this hodgepodge of nonsense, which never really rewards anybody adequately year to year, except for maybe the hospitals, which constantly will push back on site neutral payments and things like that. And that's where there's hundreds of billions of dollars over a time horizon to save. I would argue that should be invested back to solve some of these rate problems throughout, and maybe as a down payment on equalizing rates, because our employer coverage will begin to just collapse over time if we do not do something.
And by the way, I know this isn't lost on you, Mark. By the way, all these issues with benefit and coverage erosion and costs going up for patients, reimbursement down for providers, you really only have this problem if there's any physicians to treat you, because we're on this bridge that is falling apart underneath our feet.
Yep, absolutely.
Who's gonna treat you in 5 years if nobody wants to be a physician and I retire early and pursue other work?
Yeah.
I mean, then you really have a problem.
Funny story. I'm going to give credit. In my book, I talk a lot about the impact of the uninsured and underinsured. And I got onto that from the most unlikely source. Again, I'm a Republican, fairly moderate. But the guy that put me onto that was Bernie Sanders.
Mm.
Now, I don't agree with him on Medicare for all. I think that would be a travesty. It really wouldn't work well. But Bernie Sanders and I have much more in common than you would ever think. And he really has championed the idea that the underinsured is a huge problem in this country and we got to solve it.
I'm going to reserve my snarky comment there. We'll move on. We'll move on. Not about your learnings from Bernie, but related to the ACA and how fiercely that's championed, despite getting coverage for so many, yet
Yeah.
not yielding tangible benefits
It's
for the
it's
majority.
a great point. The lower guys in the ACA with very little premiums and cost sharing, they don't care about the cost because it's being funded by the government. But as you move up in the ACA, as you're pointing out, you're insured, but you're underinsured and you can't access. That's the real failure of the ACA.
Shouldn't laugh, but the irony there is just too juicy for me.
Yep.
So to get us back on track, I know one of the early on it was kind of a head scratcher. I had Scott Becker on this very show in December. He brought up Dr. Oz and kind of had like a wait and see type mentality. Like, don't really know about his actual chops, what his credentials really are, but he seems intelligent enough, so
Yep.
we'll find out. But he was confirmed mid March.
Yep.
What did we learn about there?
So again, when I looked at Oz's Senate campaign in Pennsylvania a few years ago, I was not terribly impressed with the guy, right? And I was a little suspicious of his, reality star type of things and some of his investments and some of what he has said in the past. But I was quite pleased. I watched his confirmation hearing, and he came off as incredibly knowledgeable and I think very qualified. That, unfortunately, for me, stands in stark contrast to RFK Jr. I thought his confirmation hearings were terrible. He could not even articulate the basics of Medicare and Medicaid. And when you're the chief health official of the United States, to me, that's a bit of a travesty, right? But Dr. Oz sat there, took questions, went deep into issues, and he is very knowledgeable. I also like the fact that he's a provider. Sometimes I don't always agree with providers on certain issues, but I think the fact that he's a provider and understands the health system is really good. But he showed a level of, thoughtfulness, knowledge, and I think qualification that was really good. And I know he's still controversial, right? But I do think he's going to do some very good things. And I think he's going to be a very competent administrator at CMS. And to me, I more worry about things like CMS and the FDA than I do who's the HHS secretary, because I think those other positions, and again, I know Marty McCary pretty well, and that guy is going to reform the FDA, and he's going to do it with science, and he's going to do it very thoughtful, right? So to me, those are two very important positions. A little bit about NIH, and I'm worried about that one because of the grants. But getting back to Oz, at that hearing, he said some very important things. He said again that he is backing the drug price law in so many ways. And I think when you have the CMS administrator of a Republican administration saying those things, I do think you're going to have change. And I think you're going to keep the Medicare drug price law, and you're going to probably even strengthen that Medicare drug price law, because I think they are, both Trump and he are really out there saying we got to do something on drug pricing. Now, I don't discount the fact that big pharma could use their lobbying leverage in Congress and things like that. But I think having both Trump and Oz championing drug price change is good. And he even mentioned international reference pricing, which is the ultimate drug price strategy, right? Which is benchmarking our prices against other developed world countries. He is a big supporter of Medicare Advantage, so am I. But contrary to popular opinion, he actually called out that we need great and massive reform in MA as well. And he cited, along with some progressives on the committee, along with some conservative Republicans, that overpayments and risk adjustment in MA needs to be changed. I probably wouldn't go as far as they might, but that is an issue that's going to happen, whether it's in the reconciliation bill or through regulation at CMS. And that just sort of proves sometimes your biggest friends of a program may also be the biggest reformers of a program, because they're honest brokers and they say it's a good program, but we are not going to put up with these overpayments, in this case in MA.
Well, I think that's an interesting talking point too, because it's not really something you could measure. I mean, you could, commission as many polls as you would want to survey Americans. What do you think about this? What do you think about that? But you can't really get a sense for what everybody is feeling. But they're just, you can feel it in the air, like it when you know it, and that's the opposite of scientific. But you can just kind of feel it, I think, and I feel it, that if you were to put the information around domestic drug prices versus international drug prices in front of anybody in America, there would be a big question. Why are we paying so much more?
Yep.
Do the companies based here hate us? Are we footing the bill for people that we don't know that should be buying this for the same price that we are? That's not an unreasonable position. That's not a position built on a foundation of hate or prejudice. It's just a question. Why are we paying more? And that goes right back to the point around the overpayments that you referenced as well. mistakes happen. There needs to be an accounting for mistakes. Hey, we overpaid here. We're going to have to short pay you, doc, on the next one, just to round it out, get square.
Yep.
But intentional overpayments without any oversight, this is going back to that sort of the sentiment that's maybe simmering at this point. We shouldn't be overpaying anybody.
Yep.
Who's at the wheel here? What is going on if we're the fraud, waste, and abuse that's so rampant in the news? Like, is that just okay? But now we have a measurement for it, and people are upset, and I think reasonably so.
No, I think it's a great point. And I would like to see comprehensive healthcare reform, right? But I think one of the benefits of this look at fraud, waste, and abuse, as you know, will take fat out of the system and will force some change. I hope it's rational and things like that. That's my big worry. Will it be rational? If we can combine sort of true attacks on waste, fraud, and abuse and overpayment and things like that, along with sort of rational healthcare reform, we would be so much better off, I think. But maybe we're inching towards some change here, is my optimistic look at this. I don't know if that will happen, but it's my optimistic look here. And back to your point on, the overpayments, and we talked a little bit of hospitals, from just being a political observer for years and years, I will give the hospital lobbies and the drug lobbies huge credit for what they've done. I don't agree with it, but they have won over lawmakers and administrators in the executive branch like nobody's business. And if somebody is looking for a way to have a successful political lobbying campaign, I think it's excessive and needs reform. But I would go to the big pharma playbook and I would go to the hospital playbook because they really have done a good job at the expense, I think, of the American public and a good healthcare system. But just from a political observer standpoint, they're tremendous, right? And
Right.
in some ways, their lobbyists deserve the money they're making because they've delivered for their constituencies. It's a little
I
bit of a
want,
sinister type of look at it, Eric, I admit.
well, they're highly effective. There's no question there, but it's also sort of like the never ending cycle of our services are super expensive. The American people want them cheaper, but we take the money that the American people are paying our company and going straight back to Congress and paying them to be sure that there's no price control put in place, and then
Yeah.
rinse, repeats until we're at a point where 1 unit of insulin is a car payment and more.
Exactly. Yep, absolutely right. And one of the other areas I've recently studied, if I could add, is there's actually a weird thing between health plans and hospitals when it comes to rates. And it really dawned on me one day, and I probably didn't think about it when I was actually negotiating hospital rates way back when, right, at a health plan. But the hospitals argue Medicare and Medicaid payments are too low, and we have to charge the commercial and the employer sector, multiples of what we get paid in Medicare, right? And the differentials are amazing. And when they do that, it means they don't have to be efficient. They can just ask anything they want from the employer sector. They can lobby for some Medicare increase and some Medicaid increases at the state level with slush funds. So they get Medicaid slush funds. They do better on Medicare than most providers, as we know. And then they ask for exorbitant rates. And very few hospitals thus have reformed. There are some good ones out there that actually make money on Medicaid and Medicare. But the vast majority are inefficient, they're bloated, and they just love the game they've created, right? Health plans, though, contribute to that because, health plans have to stay at Medicaid rates. They are low, and the way they make money there, if they make money at all, they have to keep the Medicaid rates. So providers and plans pretty much stay close to Medicaid rates. What they then do, health plans with providers, is especially hospitals, some other providers, but largely hospitals, is they go and health plans are complicit and agree to those huge increases in rates over Medicare in the employer sector largely because the health plans aren't at risk. It's self-insured funds under ERISA. So they're happy paying 200 and 300% to a hospital or another provider of Medicare because it's not on their balance sheet. They're getting an administrative fee and it's not on their balance sheet. And what they do is they say to that provider, I'll agree to these employer coverage excessive costs if you give me something close to Medicare and Medicare Advantage, because that's where I make money, where I'm at risk. So the health plans are as guilty as anyone in terms of this huge inflation in the employer sector. And it's very much lost on people, right? So I've begun criticizing health plans as much as the hospitals on these employer things because it just perpetuates this huge waste and inefficiency in the system.
There's a lot of really good reasons to throw spears at the carriers. Every single one. You can see them online. Some of the reasons for denial of care. You as a physician get into a peer-to-peer review for medical necessity, and you're an orthopedic surgeon talking to it. And this isn't to take a shot at nurse practitioners, but they're not an orthopedic surgeon. They're a nurse practitioner. Is that peer-to-peer?
Yep.
It isn't.
Yep. Understood. Hey, on that topic, Oz also at his confirmation hearing really said he wants to work with Congress on further pulling in prior authorization and claims denials. So that's another point where he's a friend of MA theoretically, but he's now in the middle of that friendship saying we have to reform. And between the progressives on PAs and even like the Bill Cassidys, who are fairly moderate to conservative leaders in the Senate, they're all over this issue too. So you're going to continue to see change there. And on other podcasts, we've talked about, I'm a believer in the correct use of PA. I hope that doesn't go away because I think there is a role, but you will see more changes there for sure.
Well, we're kind of getting to the conclusion of an arms race with denials for prior authorizations for any type of procedure, and even just straight up payment denials as well on claims. That the arms race is the carrier sends back an AI generated nope, claim was denied.
Yep.
Figure it out. Practices and healthcare organizations are now going and doing the exact same thing, pulling in references, pulling in the patient's chart, having LLMs write up the letter, send it back. So something's got to give. You can't have healthcare or provider organizations and carriers just nuking each other with LLM generated letters back and forth. Like nothing's going to happen. Just let the robots hash it out. Like they're not going to reach a conclusion.
Yeah. And I think you're absolutely right. And I dream of a day where for the most important services that might be abused, PA should be there. But right now, as I say, plans are saving cents and not dollars. If they really truly pivot to a care management model and a reimbursement model with providers that incent provider for efficiency and quality performance in tandem with plans, we would save dollars. We're saving cents. It's an old legacy system that needs to go away in terms of how plans operate prior auth and even the claims practices as well.
Agreed. We could spend the rest of the day talking about all that's wrong and funny anecdotes there, but I know we're getting near to the end of our time together today, Mark.
Yep.
We got pretty deep into fixing Medicare on the physician side. Was there anything we glossed over, or any other points we wanted to make on all the places we could use a magic wand?
No, again, I just feel like a fix for 25 for physicians is absolutely critical. There's been a loose commitment to the doctors caucus to do it in budget reconciliation. I hope it happens, but I don't think it's going to be a permanent fix. There's got to be a permanent fix because you'll have the further erosion of independent practices. 70 to 75% of doctors today either are owned by hospitals, owned by private equity, or owned by health plans. There's no independence there. And number two, again, primary care will continue to erode. And we have to bolster primary care. So in tandem with fixing the Medicare physician rate, we should actually be investing money in Medicare to increase rates and foundationally find a way to get back to primary care in the country.
The profession's on life support. I don't want to get totally up on my soapbox here, but people that aren't plugged into healthcare, like you are, or people that don't work in the space, they have no idea this is coming. It's not on the news. No sites outside of Becker's healthcare portfolio of sites is reporting on this cataclysm. Like the asteroid is in the atmosphere now. It's not too late to fix the problem, but
Yep.
primary care as a job
Yep.
doesn't look good. Something needs to change foundationally.
Yep. I love your reference to Becker's because I'm a convert on Becker's. I wasn't really reading it every day, but for my news feed now, I rely a lot on Becker's. I used to be a fierce healthcare, which I think is good, and a
Mhm.
modern healthcare, which is pretty good. But I actually look at the Becker's provider and hospital site as well as the Becker's payer site. It's phenomenal. They cover so much more news. Really, really good.
And Scott's a friend of the show. Like I mentioned, he was on in December. I don't know how he does it. He's a force of nature himself, but what an incredible team to do that much content. I cannot fathom how he does it, but I'm glad he
Yeah.
does.
And I love the short briefs with press on the link to go deeper if you need to, because you get everything. And then if you want to go deeper, you go deeper. So, yeah.
Yeah, I agree. I agree. So outside of our shared respect for Becker's healthcare, what else is on the horizon? What other trends do you see materializing now through the end of the year or beyond?
Sure. I think we talked a lot about the budget and the cuts and things like that. I'd mention a couple of other things. So, antitrust. Everybody felt that antitrust scrutiny was going to go away under Trump. He's more pro business and things like that. Biden had done an executive order on antitrust and was really sort of beefing up. And I'm critical of both Democrats and Republican administrations throughout the years. I'm a little more Teddy Roosevelt than most Republicans. I'm a big antitrust guy. I'm a trust buster. I may whine about the fact that a given health plan merger may have died or a provider merger and it wasn't fair. But if you look across the continuum, the consolidation, whether it's provider and provider, payer and payer, or payer and provider, has really raised cost in the country. And it's created an anti competitive environment. I believe that companies like United Healthcare and some of the other big guys ultimately need to be broken up because the dominance of the industry and the lack of transparency and price and things like that, that's one of our source problems here, right? And I think the Change Healthcare thing proved it. They didn't care about their infrastructure, and most of the country was relying on it, and they were just making margin without bringing true improvement. And to me, that's what these big mega corporations do historically, whether it's healthcare or big oil or what have you. It doesn't matter. That's what happens. So I think Donald Trump is going to be almost as aggressive as Biden on antitrust. And I think that's very important in healthcare. And frankly, honestly, across the entire economy, because I think there are examples in almost every sector where consolidation has become a big problem. PBMs, part of that consolidation concept, because 70 to 80%, depending on the stat you use, are three PBMs in the country, right? So I think PBM reform will happen as well. Um, so I think those are probably two other big ones I didn't mention earlier that I think will happen.
Obviously, the antitrust side of this is driven, by the executive branch of our government. How do you see PBM reform being handled? Who's going to take the wheel on that? I guess.
Yeah, well, I think part of it will happen through FDA, CMS, and HHS, and it's going to be more regulatory about transparency and reporting and accountability and things like that. But I also think that Congress is going to pass some changes that will be very good. Number one, they will pass transparency reporting as well. They will rule out certain kind of reimbursement arrangements between plans and PBMs, and then PBMs and pharmacies that have really hurt the stability of many pharmacies out there, a lot of independents as well as chains. But on the plan side, they're going to mandate transparent pricing and things like that over time. They're going to ban spread pricing, as an example. And then I also think that they will also get into areas of Orange Book reform, which allows drug makers to stop the penetration of generics, which will help indirectly. It's not exactly PBM reform. I think they will also require uh, uh, PBMs to become, again, from a transparency standpoint, they will require some of the big guys to show their books on related party reimbursement, because there's a lot of evidence, even in the FTC lawsuit, that some of the big guys have arrangements with their own health plans and their own specialty pharmacies or the retail pharmacies that are not arm's length arrangements and actually are raising prices for consumers, but also for employer groups and the government and things like that. So it's a bit of an arcane mess. It's so opaque that pulling it back is difficult. And I haven't even done a great job of explaining it because it's so opaque. But they will go after these little areas in PBM reform that will make it work. Now, I think PBMs do some good things. I want to go back to the brand drug maker, as we've talked about, because they're as much a part of the problem as anything. So price reform is key too. You got to really do both to rationalize drug pricing.
Well, and your points about Trump being a populist are, very much true. I think that's just an objective fact. So love or hate Trump, and then looking towards what he will view as his legacy, helping the common American, the common man, the common woman, however you want to phrase it, pay less for their healthcare. I think that'll probably be on his radar. So I'm hopeful, just as a consumer of healthcare myself, that costs can go down.
Yep.
That'd be great.
I absolutely agree. But as I point out, I like some of the changes and I hope they're reasonable. But it would be really nice to pair it with rational healthcare reform. I don't predict that's going to happen, unfortunately, because of the state of American politics. But they got to start thinking about the issue. And I'm really, really very worried about employer coverage. I think it's become untenable, as you noted earlier.
Well, it's insane. And as a quick anecdote, in years gone by, I was personally covered by my employer, but the employer's decision was that if you wanted your family, and I got a wife and two great kids, if you wanted your family covered, then you are really going to have to pay. And it felt kind of like you were just going to pay for all of that. There was no
Yeah,
employer there. For it to be less expensive somehow, and you're based in Florida as well, for it to somehow be less expensive for me to insure my wife and kids separately from my employer plan with Florida Blue directly,
yeah.
yikes. Because anybody that has had to go through that process knows that is not inexpensive, and you don't feel good about it. You feel bad paying that. It's just insane.
Absolutely. And, I retired from a very large tech firm, several hundred employees. We had some wherewithal. We struggle with providing good healthcare coverage just because costs were going up. Right now, as you know, Lilac is a relatively new company. We're struggling with how to fashion healthcare affordably for our employees. We're a healthcare company, so we want to make a commitment. But again, costs are high. I'm also on the board of a police artificial intelligence law enforcement company that I do a lot of work for. They're in the same boat. We're talking starting with ICRA because it's probably the best way we can funnel good money to people to buy in the individual sector, because it actually, as you point out, is cheaper than maybe providing employer sponsored coverage right now until it gets larger. So there's all these weird things out there that are happening that is just a signal that we're in real trouble.
Well, I'll add to that. This could be the topic for another show. The next time you're back on, what's even fair? If you're going to offer coverage to your employees, what even is fair now? There's so many nooks and crannies. People that are generally healthy, probably get the better end of this deal. But for those that need more regular care or faced with a chronic condition out of their control, like what even is fair? How much cost do you expect them to bear? I don't have the answer. I'm
I,
not sure anybody.
I think it's a great point. I think comprehensive coverage is important to serve those people with chronic conditions so they don't cost the system more money down the road. But there's also excess throughout the healthcare system in terms of benefits. We should have a good comprehensive standard benefit for everybody across these lines of business. I'll take, for example, in Medicaid, one of my worries there is we have southern states that don't provide much benefit or coverage at all. Dumb. Uh, and then in, say, a California, not to pick on them, but they seem to have a really excess in terms of coverage and benefits. And where's that happy, comprehensive medium that can help rationalize the system? I think you're absolutely right.
Yeah. Well, we'll cover that one on the next one in more detail,
Sounds
Mark.
great.
Until then, where can our listeners get in touch with you online? Where can they reach out on social media, your website? Where can they get more Marc Ryan?
Sure. Well, a couple ways. Number one, on LinkedIn, that's my only social media. And you just search Mark S. Ryan and you'll find me on LinkedIn. Would love to hear from people. Lilacsoftware.com is my main healthcare venture right now with two co-founders and I. And then if you want to learn about healthcare every day, I do a daily news feed, I do 2 blogs a week, and I do a weekly podcast. And you can go to healthcarelabyrinth.com, sign up and get emails or follow me on LinkedIn and go there each day. But it's sort of a comprehensive news feed that brings in Becker's and Fierce and Modern and gives a little bit of my commentary there. And then I deep dive on blogs and podcasts too.
I was just going to say, you took the words out of my mouth in a way. You're giving the Becker's Healthcare portfolio a run for its money with all that content and great content too.
Well, I appreciate it. Thanks a lot. And Eric, as always, it's a pleasure to be with you. It's really fun, going back and forth on healthcare, and it's amazing. So many things are changing. So next week it could be totally different.
Well, as you put it, we can get some rational reform, some common sense stuff across the line. I think that will make everybody happier, with maybe the exception of the carriers, and that's okay.
Yep.
So until next time, I am your host, Eric. If you're not already subscribed to the DocBuddy Journal on Apple Podcasts, Spotify, and YouTube, go ahead and hit that button. That way you always get the newest episodes of the show, and we will talk to you again soon.